A story is told about 10 chickens that were crossing the road. Come on, everybody. Hello. A story is told. A story. Everyone is interrupting me. Come on in. Everybody, come on in. I'm going to bully people now. Now it's bully time. I'm going to bully you all. Michael, I can still see you there. So a story is told about 10 chickens that were crossing the road. Come on, everybody. I'm trying to get your attention. 10 chickens were crossing the road. 10 chickens were crossing the road. 10 chickens were crossing the road. Then suddenly, there was a helicopter passing by. And you know, nowadays, when you see a helicopter, you got to duck because you don't know when it's coming down, right? So there's a helicopter passing by. And there were 10 chickens crossing the road, right? 10 chickens crossing the road. And the chickens started to look up to see what's going on. Where is this helicopter coming down, right? How many eyes were looking up? The answers, how many eyes were looking up? Who say 10? Somebody say 10. Remember, how many eyes does a chicken have? Okay. How many? Okay. So how many eyes were looking up? Huh? 20? There's 20 here. Anyone saying 15 eyes? I didn't tell you whether all of them had 2 eyes. But anybody saying there's 10 this side, there is 20 that side. Any more? 10 on this side. Why 10? 0 eyes looking up. Why? Because chickens don't care about helicopters falling on them. But chickens get scared, right? Right? So how many do we have? They all ran away. Just take off wherever you're going. Nobody cares, right? How many eyes were looking up? And why? Somebody said 1. That's amazing. Innovation says it could be anywhere from 1 to 100. That's innovative way of looking at it, right? Maybe some of them had glasses. Who knows, right? But generally, why would you say 10? Why not 20? Aha. Aha. You see what she said? That the chicken have the eyes on the side, so maybe they had to tilt their head to look, right? How do we know? Maybe they had binoculars or whatever it is, and they were able to use that. Anyways, I think the answer is anywhere between 10 and 20. Could be more. Great, I got your attention now. So today we're going to have, I'm going to introduce somebody very special. This gentleman flew from very far to be with us. And one of the biggest things he does, one of the amazing things he does, is that he helps with smart cities, designing, and he is the president of the World Smart Cities. Now, for those who've lived in northeastern US, those who've lived in Kenya, I'll say Kenya in total, there are so many things where cities just grew. There's no plan, there's nothing, and you find yourself, in Boston, you'd be going this direction, and then few blocks down the line, it's a one-way coming this way. So suddenly you have to look for a way to go back and go around and go. So it's the way the cities grew up very fast. So I'm going to invite Mr. Peter Chung to come at least and say something, at least give him 2 minutes, tell us who he is and what he does. Followed by, we'll have another amazing 15-minute presentation from a teacher. So pay attention. Here you go, sir.
Thank you very much. Hi, nice to meet you, everybody. Did you enjoy the meal? Lunch, okay. I flew from South Korea. Actually, I was in Osaka yesterday. Actually, the day before yesterday. Temperature was there. It's like 33 degrees and 35 degrees in Celsius. And I never expected this kind of weather. I was almost had a cold. in the morning. So it's a beautiful weather you got. What I do, thank you very much for a very charming introduction for me. I build smart cities around the world, and what I do right now in Kenya is we are building the medical city in Kisumu. We have like multiple initiatives around the world. We started focusing on the healthcare with a cancer center. My sister passed away last year, and she's a celebrity in South Korea. And Governor Nyong'o, the governor of Kisumu County, and our foundation agreed on building the cancer hospital to take care of the saving a lot of lives. We don't know exactly what kind of cancer we have. We have some statistical numbers, but some numbers we don't know because of some numbers is outdated. We're trying to build this hospital with activities, starting with early cancer screening programs. And we are going to make the official announcement. We already did. Maybe some people here visited Kisumu. We already had a ceremony of unveiling plaque of Chanjang Nyong'o Cancer Center at the site of Victoria Hospital next to Jaramogi Odinga Hospital there. And we are going to make another announcement to kick off the early cancer detection programs around Kenya. This August 17, 18, so we are going to have the International Cancer Forum at the Old Sereni Hotel on the 17th of August, Monday. And we are going to have the International Summit for ASCA. So I'm the president of ASCA, and we appointed Governor Nyong'o as the chairman of ASCA. ASCA means Africa Smart Cities and Townships Alliance. So the pilot project is about the cancer center and saving lives. So if you have any questions later on, I can probably maybe jump in the kind of panel discussions and speech about what we do. And our website is asca21.org. You can maybe find some more information about it. I'm looking forward to speaking with you. Thank you.
I think I should say Kamsamida. Okay, so next, I hope you follow that. Next is going to be Teacher Allison. Teacher Allison is going to be with us. I think Mwalimu Harris Allison is what is actually the best way to say it. So please take it over.
Thank you. Good afternoon. All protocols respectfully observed. Thank you for having me today. I'm delighted to share a global health project with you that I've been involved in with my partner, Barty from Kissy, an oncoplast breast surgeon, who's been phenomenal. And we're going to talk about a project we've run together, which was aimed to reduce the global burden of cancer. And our focus has been on Kenya, Uganda, and also the UK. So it's been a real true partnership. And it's also involved Uganda partner, Jane Francis. So next slide, please. I've got an assistant because I've got some videos. So just really our timeline, 2020 is familiar time, COVID hit. But we continued the partnership. So the Christie Hospital, where I'm based, we was curious whether we could work with Uganda in partnership and do something linked to oncology. And Sister Francis, following a meeting, contacted us to say, could we help design a master's in oncology? We have no funding. It's very complicated. But the questions was raised, how would that help the system to have a small number of specialist nurses in oncology? Let's think about who people in our communities meet day to day to talk about their health and social care in our communities. And it's unlikely it's going to be a specialist nurse in oncology. That's further down the stream. So at that time, Barty joined because it was the start of the Kenya-UK Health Alliance. So she joined the project. And what we thought we could do together was think about how we would scale clinical education that would be meaningful and change behaviours to strengthen awareness and outcomes in cancer across the system. And think about what was the biggest impact we could have. So it's great to hear from early detection, prevention, because if we think about cancer, the World Health Organization tells us 30% of cancers are preventable. Etiologically, astringent factors, exercise, diet, smoking cessation, protective equipment when farming, for example. So many things. So could we start with sharing what cancer is, what causes cancer, and how we can prevent it, or at least minimize risk? We then thought about how could we deliver training at pace, where we could free up workforce, whether they be nurses, whether they be healthcare workers, field workers, community workers. And how could we create a curriculum where we'd all benefit from the foundations of oncology? Now, I'm going to be clear, in the UK, pre-registration nurses do not have a strong oncology curriculum. Yet 1 in 2 in England were affected by cancer in a lifetime. The difference is we're slightly ahead of the curve with resourcing, and many of those cancers are detected early through significant public health messaging and diagnostics. So that's where we started. We then came to a model agreement, and we carried out train the trainer in Nairobi, and colleagues came from across the region and experienced the training to see if it would work. And then later on, we managed to get a THET grant, Tropical Health Education Trust. We got £50,000, and we looked at how we could, in Kenya, socialise the module to fit communities and meet people where they are. This now has created the global blueprint for system strengthening of oncology. So let's talk through the process. It's a bit of a story, and I'm hoping that the Kenyan voices will come out the most strong in this project. Next slide, please. So curriculum design is a spiral curriculum. When your community say to you, I've been told I've got cancer, but what exactly is it? How many of us could answer that with knowledge, confidence, capability, fearless? And perhaps that's the way to start. So we're thinking about what is cancer? What are the causes of cancer? How can it be prevented? If it can't be prevented, how can we detect cancer early? We are thinking then about the types of cancer treatments available in communities and how that may be a burden where not all communities will have access to those specialist treatments. So really thinking about how do you serve your community. We needed a curriculum that was quality assured. So whether you was in Uganda, England or Kenya, you got the same standard of training. So it's very much facilitator-led, where all the questions and answers were in the material. This module was not a taught module, what we call programme knowledge in academia, the textbook. This was about having rich conversations about lived experience, being able to contextualise the material and for peer discussions around what people knew, didn't know, deconstruct and reconstruct about the topic. We then went through and integrated local voices that we'll talk about as we generated more funding. We evaluated the project, and we've now linked this with a call of action, what we call behavioural changes. Next slide, please. So that's the spiral curriculum, and it follows the cancer pathway. So we start with preparing our participants to give them a health warning themselves. We're going to talk about cancer. And many participants feared that, despite being health professionals, because they have their own trauma of cancer. And we began to open up conversations safely, and colleagues would share experiences. And we then went through the material. So, for example, we'd say, here's a video from a histopathologist, and he's talking about cancer. And I tried to find a global majority histopathologist so our colleagues could identify with that individual, and so on. So that was a general curriculum, and that's where we tested train the trainer. Next slide, please. So we came to Kenyatta, and John was able to mobilise colleagues from across the country to come and join. We had about 50 participants in Train the Trainer, just really to test the model. Next slide, please. And then we jumped over the water or through the air to partners in Uganda, and we did the same programme and tested it in the same way. So what you can see here is our Ugandan colleagues actually delivering the training and being able to follow the facilitator guidelines. Because you work with people with cancer, it doesn't make you an expert in cancer. So what we're finding is that, and equally in the UK, many nurses may work in cancer, but they never got the foundations. And then they go so far through their experience and they're a little bit embarrassed to ask. And so we compound the issue. So everything was facilitator guide and all the facts were in the material. Next slide, please. Let's hear from one of the participants and impact.
My name is Jacinta Virunji. I am a nurse who works in the cancer department. I work for St. Francis Hospital Sangre. It is a non-governmental organization, not-for-profit. I've been working for quite some good time, and I think I had some knowledge about cancer.
Okay, Sister Jacinta, what has been your experience being part of this Foundations in Oncology Nursing course?
I've had a good experience. Actually, as I was introducing myself, I said I had some knowledge of cancer, but I got to find out that the knowledge I had a meaning, but so what? How do I have to give it to the people or the patients who are near me or the persons who need that care? So the experience I have gone through this time, now I realize my role on how to take care of these patients and how to give the knowledge back to another person who has not had this program before.
Is there anything you learned from this program that will impact your practice?
There's a lot that I have learned that has impacted on my practice, especially on how I've not been with a feeling of teaching. I've been with it, but how to deliver it. This time I have known how to educate in a better way. And I have now known how to care for my patients in a better way because I have learned how to care for a cancer patient. I have learned how to give knowledge to those who are just taking care of the patients.
What is your hope for that program?
My hope for this program is too big, I must say, because this is the beginning. From the beginning, I don't know how I came to have that in mind. I wanted a certificate. But there was a question. If you don't know your role as a nurse, how about a certificate? What is it going to do? So I have to know what I'm supposed to do to my clients and the patients so that there is a good service delivered to them. Then the burden of cancer can be reduced if everyone knows where to go, what time, and what to do at a time.
Next slide, please. So our next funding, we managed to secure an opportunity to decentralise the training. So what we decided to do, well, Barty led, was go to 4 regions. We went to Kisii, Mombasa, Nakuru, and Garissa. And what we really wanted to do then was tailor this training to meet those community needs and really integrate that lived experience. Next slide, please. And so we had the same curriculum, but this time, instead of saying, what is cancer and what are the trends, we would say, what is cancer and what are the trends in Kissi? What are the trends in Garissa? What is the trends in Nakuru? And so on. And they were different. The focus needs to be different because communities have different beliefs, different needs, different exposure. We'd then be thinking about resources available in those communities and how the communities have belief around cancer and seeking out early detection. And so we really tailored the programme. Next slide, please. So what you can see here is our what we call project initiation. We came out to Kenya, we went to the 4 regions, and we introduced the concept and mobilised groups of around 10 to 15 colleagues that would start to work on their material. Next slide, please. We then loaded material onto MS Teams so that we could integrate it into modules that suited those counties. Next slide, please. And each county then found their experts to share their experiences of looking after people affected by cancer in their communities. We also collected lived experience ethically of patients who had stories that they wanted to share, and they would do that in English or they do that in their local language, and that was really impactful, really how people feel and the impact of this diagnosis and treatment. Next slide, please. And here's a very brief example, in the interest of time, of one of our colleagues in Mombasa.
Hello, Esther. Tell us more about chemotherapy.
Hello, my name is Esther Masele, Oncology Clinical Officer at Coast General Hospital in Mombasa County. I'm talking about the role of chemotherapy in cancer care, where chemotherapy are drugs which are used to treat cancer cells after diagnosis is made, where they can be given
Next slide,
as a
please.
form of
What was really interesting was I didn't understand a word that my colleagues said, but what struck me was in the first round of training, nobody would have understood me. And so it was, a holding mirror up to self. I'm just going to share what one of our IT colleagues said, who undertook and supported the training, but then evaluated the impact of the training on him.
Hello, my name is Humphrey Musava, ICT officer in charge of Nakuru County Referral and Teaching Hospital. My first time to hear of the word cancer, what came to my mind was that this is a disease that is incurable, a disease that shatters people's dreams, a disease that causes financial burden to both family and community at large, a disease that causes psychological and mental breakdown, and also a disease that terminates people's lives. I have come to learn that that's not true. Through this program, Foundation in Oncology, I have been able also to learn that if proper public awareness is done on time, this will lead to patients being screened on time, and this will make it possible for proper management of this disease. My role in the community is to ensure public access to this information, especially through social media platforms, for early detection and management. Thank you.
So that's great because it shows all our communities have a role Here in Kissy, we're doing a little dance to really demonstrate pain, which we won't show in the interest of time, but it was really interesting, the cultural elements of how we express ourselves as patients and clients. Next slide, please. The programme has been evaluated not only on knowledge, but also on confidence that leads to changes in behaviour, and we really focused on a call for action. So this isn't about what you know, how confident you are, but really what you're going to do. What are your next steps to have a call for action? And this work has been statistically analysed. We do wider work and showing a shift statistically in self-assessed knowledge and confidence gains. Next slide, please. And so the partnership key principles have been: cancer is a global burden, it's a shared burden. We need to strengthen across a system. Everybody has a role. We need to meet communities where they are and understand their journey. Cancer is a social construct, and therefore everybody will have different belief systems, myth-busting, etc. Local communities tell their story best. And the core module can be adopted now, potentially, for a national programme because it's so diverse and meets so many community needs. And that's the end of my presentation. Thank you.
Come on, better than that. Come on. It's very rare we have presentations where we have our voices there. Normally, it's only you hear what we want to say, but here's where you heard from the people who are benefiting from it. Now we're coming to the panel. So this is where if you have pitches, if you are doing any of those interesting things about pitching, I will allow you to this time not come into the door, this time walking out of the door, cross the road. Please remember the chickens that were crossing the road, cross to the other side. There is the pitching area there where people are pitching about their ideas. Meanwhile, for those who are nerds, those who want to talk about cancer and kidney disease and a few other things and clinical trials, you stay here and we'll have a very good conversation. Now, I'm going to request for those who can, if we all come to the middle here where we see each other and where we can ask questions together, it will be great. If you need to sit where you're sitting, that's fine too. So I'm going to start inviting the folks who are going to be in the front. We're going to help guide us. So those who are going for pitches, a couple people asked me, where is the pitching being done? It's across the street. That's where they are making the money. So names one by one, and we come up. So I have, okay. You know yourself, come on now. So we have Dr. Joanne Simam. Come up, please. We have Dr. Rose Jalango. Please come up. And then we have, for Dr. Melly, we have Dr. Emily Barsitoy. Come up, please. And then I lost the other one. Washira, you're coming for Dr. Jalango. Oh, there you go, okay. He knew. Now I've lost a page. This is crazy. Okay. Kerry Jones, are you here, Kerry Jones? Please come up. Oh, there you are. And Lydia Okutoi. She's left, okay. And then we would have Amit Bakri. Yes, it's time to go there. If you want to go, good. So I'm going to allow, again, like we did earlier on, 1.5 minute, 2 minutes of what you do. We'll start from Amit going down. Just a minute or two, maximum, what you do, your name and what you do. Thank you.
Hello, and those of you who are still keen to be in this room and not go to the other room, a very warm afternoon. My name is Amit. I work for AstraZeneca, and I head the operation for the Sub-Sahara Africa. We have a huge interest in NCDs, be it chronic kidney disease, be it cancer. Yesterday, I was fortunate enough to also lead a panel here where we talked a lot about what we do, but hopefully in this panel, we'll be able to discuss what AstraZeneca role is as an industry for tackling a disease like CKD. Thank you.
Good afternoon. Thank you for the opportunity to introduce our work. My name is Dr. Kerry Jones. I'm a retired consultant in anesthesiology and intensive care from the UK. I've been coming to Kenya for 17 years, bringing different projects aimed at key areas of death and disability. The first is trauma surgery, trauma care, such a high death rate and disability rate. And we have also introduced subsequent programs helping staff to recognize the sick or deteriorating patients, which is such a high cause of mortality from late referrals. We also wanted to introduce ability for people locally to make improvements for themselves and designed a program around quality and teaching skills in quality improvement and leadership for frontline health workers, because that is where quality starts or fails. And we now have a partnership program initiated through KUKA in critical care, where we share practice from the UK virtually online with hospitals in Kenya, including the Kenyatta National Hospital. And we've recently hosted several practitioners in the UK to observe critical care practice there. And we've also done some work in maternity and newborn resuscitation. But quality is really a particular focus of ours. I'm sorry, Dr. Okitoy is gone. She's head of quality and safety. Oh, okay. So can I let her speak of her work on quality and safety in Kenya?
Thank you for the opportunity. Sorry that I've come when you're ongoing. Actually, I've been told this has been postponed till tomorrow, but I'm here. So my name is Dr. Lydia Okitoy. My background is in obstetrics and gynae, but I support healthcare quality at Kenyatta National Hospital as the director for quality. But at the same time, on a national front, where Kerry helps us, we have a professional association called SQHK, Society for Quality Healthcare Kenya. Kerry sits on the board, which is a multidisciplinary professional association, just being the thought leaders around quality and safety, and at the same time, seeing at capacity building level, at training, how can this be embedded at the healthcare facility, because we are where we are more trained on technical skills, but the others on improvement, which is now a non-discipline, it is just touched a bit. So we exist to support that. So far we've held I think we're going to have our second scientific conference this year, but we've been in existence for 5 years. Some of the milestones that we've done a training needs analysis towards integration of patient-centeredness, patient safety, and just the improvement science into the curriculum for the healthcare providers at pre-service. That is, we did KMTC, Aga Khan University, Kenyatta Hospital, and Kijabe Hospital. And so we have that body of work that we hope to embed into a policy brief and to engage the trainers to see how we can up the game of the faculty, but at the same time, the training institution. The same training needs analysis looked at the facilities. Great. And just maybe to summarize, what else we have done is to support the quality of care bill, the patient safety and quality of care bill in the country. That is now at the level of the Senate. It was well mentioned by the PS in the morning. Thank you.
Thank you, and thank you for the opportunity. My name is Emily Basito. I'm an epidemiologist, and I work with National Cancer Institute of Kenya as the head of Directorate of Strategy, Planning, Partnerships, and Resource Mobilization. Now, National Cancer Institute of Kenya is a government agency, semi-autonomous government agency that was formed under Cancer Prevention and Control Act 2012. And this was in recognition of the rising cancer burden in the country. I know yesterday we talked so much about the cancer burden, yes, the rising cancer burden, and therefore there was need for a coordinated response to this rising cancer burden. And so at National Cancer Institute of Kenya, we coordinate and ensure that cancer care is accessible to all Kenyans. So we do quite a number of things. I'll talk about, of course, the first is policy advisory to Cabinet Secretary Health on matters cancer care. We do implementation of the policies that are developed by the Ministry of Health specifically to address the cancer burden in the country. So we do implementation of the National Cancer Control Strategy. We do cancer prevention through awareness, raising awareness, screening in collaboration with counties as health is devolved in our country. So we collaborate together with counties to ensure that there's awareness, there's screening in counties. We also look at diagnostics and treatment. And when we talk about diagnosis and treatment, we also want to ensure that all these services are accessible to all Kenyans so that every Kenyan has access to cancer care irrespective of where they live. That geography will not define their access to cancer care. And thus we have decentralization of cancer services to regional cancer centers. And there's so much that we can talk about National Cancer Institute and multi-sectoral approach to addressing cancer prevention and control. I think I'll stop there. The rest I'll answer in the questions.
Yes, you have a lot of questions that I know you got ongoing. Okay, let's go to the next. I think very well done. Okay, Joanne.
Okay, thank you. My name is Joanne Simam. I'm the head of research and data informatics directorate at NCI. So I'll briefly talk about our research and data systems at the institute. So we maintain the National Cancer Registry, which is basically a database of all cancer cases that have been diagnosed in health facilities across the country. So currently within the database, we have above 100,000 cases which have already been reported, and that's from 77 facilities offering cancer care in the country. So we also have a second database that's called Empower. So we've worked with two partners, so that's Savannah Informatics, and we also have Roche who supported us. So that system is basically tracking a patient's journey through the cancer care continuum. So from the time they come for screening, then to diagnosis, and then treatment. So that enables us to track the time between the first visit and the time they will be diagnosed, and then the first time they will get that treatment. So that enables us to get information on where the gaps are in the systems. So we are hoping to scale that up across the different facilities. So currently we are around at 55 facilities across the country. So on research, so we've had efforts to strengthen cancer research in the country. So we've supported around 20 research projects. So provided seed grants, which is not a lot of money, but then that has enabled some projects to start and provide evidence that's useful. So far, I think we've supported around 20 projects, and that is 2 rounds of calls that have been advertised before. So we also collaborate and partner in different research projects in the institute. So we're always open for collaborations on any matters related to data and research. Thank you.
Thank you, Joanne. Dr. Simam.
Good afternoon, everyone. My name is Antonio Washira. I'm working for the Ministry of Health in the Division of National Vaccines and Immunization Program. And in the Division of Vaccines, then I support vaccine supply chain and logistics, as well as advocacy, social mobilization, and communication. I am an epidemiologist by training, and just to give a brief background about NVIP, or rather the vaccines program. I mean, we are the guys associated with the elimination of smallpox and the elimination of polio, but we do not take a lot of credit for that. Because most of the times we work in obscurity. So in NVIP, what we do service delivery, ensuring that we are responsible for policy development with regards to vaccines, capacity building. We also ensure that the vaccines then supply chain is protected right from the manufacturer up to the facility and the community level, that is the last mile distribution. We also advocate for vaccine demand. We do mobilization for the communities to more towards accepting, addressing the hesitancy associated with the vaccines. We have a portfolio of about 13 antigens that we are offering currently. And the focus today here is, because also broadening our focus from childhood vaccinations to life course vaccination. Our focus here is the HPV vaccination towards the elimination of cervical cancer. And I'm happy to be here. I'm grateful. Thank you.
Great. So round of applause. Yay. You know, one of the things that I probably will come back to is especially there's a recent rise, and it is almost politically driven, of vaccine hesitancy, where everybody is coming up with a reason why not to vaccinate. But that is, it's almost the good work that vaccines did is actually eating up the vaccines. Because now, how many people have seen anybody with polio, new polio case? Exactly. So people don't understand what it means, so they talk about all these other things, because what they see, they can't see what the benefit is. Okay, so we're going to back to what you were talking about. Dr. Simam, data. Everyone has been talking about data. Everyone is worried about data privacy. Everyone is worried about monetization of data. Everyone is talking about how we collect data, how we keep it, how we deal with it. In your work, in your engagements, how do you ensure that whoever is giving you data, first of all, follows the rules, and how do you make sure they're comfortable and happy that you will treat their data with that respect? A tough question, isn't it?
So I think I'll begin with the basis. So on the legal side, so we have the Data Protection Act 2019, and then we also have the Cancer Prevention and Control Act. So that the two are the guiding principles for our work. So the Cancer Prevention and Control Act is the one that gave us the function to collect data on cancer cases, and that data is identifiable. So that's the difference. So the data is identifiable that comes into our system. And then the protection now, so we work with facilities who are also aligned to the Data Protection Act and also the confidentiality when it comes to patients' data. So access now to the data to other entities who are not either health facilities or NTI. So there's a whole guideline on how other people can access that data, which will be anonymized.
Okay.
And it has different levels of approvals.
Okay.
And then we have different levels of access at the facility and also at the county government. So at all the levels, there is protection at all levels.
Okay.
And we align to the laws.
Okay, that's very interesting because everywhere you get, any building you get into in Kenya, what do they ask you for? Your ID, ask for your phone number, and you write your name there. You just left your data there. Yet when you hear medical data moving, you're complaining, but you're just sharing your data everywhere you go. There is a way to protect yourself, and that's what she's talking about. And now, the same way, Dr. Kutoi, we have all this data that's come. How do we use that data? How do we ensure the patients are safe? This patient safety is, how do we use that data to identify areas that need attention for safety? And how do we use that data to solve that attention for safety, patient safety or quality?
Thank you for the question. I think just thinking about our hospital currently, KNH is doing the digital transformation. So we're going paperless, and one of the things we look forward to, especially as a patient safety practitioner, is we'll be able to learn at scale for what data we are able to input, because remember, you can only learn from the data that you put into the system. And so as far as health system learning health systems, when we have it digitized, then it is easier to get to know what is happening at a higher rate, or it's faster, it's at scale, and so changes can be done. Of course, that has to come with a culture of what are we putting in. Our system is being designed by the DHA people and by the KNH process owners. So that means whatever you are doing on paper, you're just making it now online, and if possible, making it better. So there's that potential of learning at scale. For example, if I'm to look at, we look at incidents or adverse drug events, that's familiar to you. Previously, even just getting to know the rate of some side effect would have to utilize a signal drug, like an antidote, and get to the system and see when was this antidote used across the hospital. And we now pick the files and we open them and check so that we have like at least a baseline of how we are doing. So patient safety data in Africa is not accurate, and we just have a lot of proxies. The process issues are to do with reporting culture. And so when we have opportunity to have an online system, we get reporting mechanisms that are anonymous, that somebody can then report. We've run one for the hospital for the past almost 7 years, but it's had little traction because it is paper-based. People are feeling like they'll be seen to be reporting, yet in healthcare, harm happens. Our target is to have zero harm, but it is not possible for it to be zero. So we need to prevent, but when it happens, we need to report and to learn. So data reporting systems help us to have that anonymous reporting system that can now help report both incidents, near misses, or anything that looks strange, to the extent that you can also report anything that is escalatable. There are things that you're not sure what is happening, but this needs to be reported for management. Maybe it's administrative.
Yes.
So I think the platforms that are available for health data could enable learning health system approaches.
Okay.
But we need to prepare to have an input that is able to make us learn, but at the same time, to have summaries, capabilities that can summarize it at the back end, and people to keep tracking it. Thank you.
So that's actually very, very, very good. I remember somebody mentioned that computer systems or electronic systems should come in to bring efficiency to a system that's there. You just mentioned or alluded to healthcare personnel not wishing or not looking for, not being shy to report situations. If they are not sure of reporting, how will they report whether it was by hand or electronically? Is there a system where we are encouraging healthcare personnel to be able to report that stuff?
Yeah, it is important for leadership to have what you call some form of transparency or just a culture of patient safety. That safety is a goal for all of us. And so anything that smells like unsafe or I'm not sure, it is of our interest. And so we'll not be afraid of being blamed. So lack of the blame culture and having a balanced accountability. When things go wrong, we look at it knowing that more often than not, the system gaps. And that is owned by the leaders. So the leader has to create that psychological safety environment. And for us to report, and you should be rewarded or clapped at. Otherwise, people will be sweeping everything under the carpet. And one time it just comes up. And it is actually a leadership attribute. And so leaders are custodians of creating an enabling environment where people feel it is safe to report. It is a premier for us to learn as an organization, not only just me, but for us to learn. And there are mechanisms, there are platforms and structures that can be done. And that should be during induction.
Okay. You
are taught and told this is how you do it.
Yes.
And your supervisor is careful to know that you're doing it or not.
Okay.
Yeah.
Great. Amit, yesterday I remember one Professor Keegan saying, maybe the cancer cases are not, maybe the reporting is better now. That's why we are able to see that there's a lot more cancer. Maybe the system is now better, he didn't say this, better to collect information about kidney disease. There is a big issue about the rise in kidney disease. So is it a question of things shifting, or is it a question of things getting more recognized?
No, absolutely. Chronic kidney disease is one of, there are different disease areas which attracts the attention, if I were to use this word very differently. If you say cancer, it's like a big bomb which is being dropped. And we heard earlier someone talking about, if it was a cancer in the video, it's incurable. You talk about hypertension, you talk about diabetes, you talk about chronic kidney disease. These are like the disease people believe are okay to have. That's an attitude which we need to change as an industry, as all the stakeholders. And I'll give you an example. In March 2026, the Ministry of Health, and I'll quote Kenya Ministry of Health example, there are 3.1 million Kenyans having a chronic kidney disease. Now, I will give you another example. In the county hospital, there was a study done, and 30% of the diabetic patients who are ambulatory are not knowing that they have a CKD, and I'm talking about a stage 3 to stage 5. Now, if a disease has a very high prevalence and a very low diagnosis, that's a very lethal disease to have. And most of these diseases, unfortunately, are very silent till the time suddenly your kidney function becomes so bad that you have to knock the door of a dialysis. Now, I'll give you one more example of how early screening can really take. Now in Kenya and most part of the world, the major reason for having a chronic kidney disease is hypertension. We are unfortunately the hub of hypertension. Hypertension prevalence here in Africa continent ranges between 20 to 28%. Diabetes is rising here. And of course, there are other causes, but diabetes and hypertension are the major cause. And unfortunately, both these diseases are silent diseases. Now, early screening can prevent a huge amount, and I'll probably, if the time gets, I'll talk about some of the initiatives which AstraZeneca is having in terms of the Healthy Heart Africa to ensure that how can early screening not only help a patient to have a very, very good prognosis, but also help the climate. You know, one of the fundamental things which are also being discussed is the interrelation of health and climate. And I'll give you an example here. You know, every dialysis, any dialysis that you have for a patient, it burns almost, or it consumes almost around 59 kilogram of carbon dioxide. Now, if I throw this number, I don't think so anyone will be able to correlate. But if I tell you this 4 hour of a dialysis equal to 59 kilogram of carbon dioxide emission is equal to 250 kilometer of your car going from one to the other place, which means 2 sessions of dialysis is as good as you taking your vehicle from here to Mombasa. So at the end of the day, that this whole climate change is also going to affect back to you in terms of the NCDs. So the early detection is something, and early detection is not a rocket science. It's not costly. Only thing is we have to have that attitude and ability to do that. For example, diagnosing hypertension early, diagnosing diabetes early with the help of a glucometer, diagnosing even the kidney health with microalbuminuria with a urine dipstick. These are some of the early markers.
That's very true. And I think one of the biggest issues, I remember having a patient who checks their glucose 3 times a week because they can't afford it. For any clinician who understands that, it's absolutely useless information because you don't know whether they took it after they ate or they took it before they ate or whatever it is. So it's absolutely not useful. Yet we report that information. So I was going to, I think, give this to Kerry about patient involvement in this. Because if, for me to notice that I have a kidney disease, I have to be able to understand. Currently, our patient knowledge, and this is, I'm going to put this on the feet of pharmacists. Patients do not usually understand the difference between disease progression and adverse effects. So when we talk here, we're talking about professionals like us. What part does a patient, or what efforts have been put in place? This is either you or Kerry. What efforts have been put in place to educate the patient so the patient can understand, even contribute to the data, the safety data that's coming in? Kerry, do you want to take this one? Okay.
So, experience of working in many places across Kenya tells me that the level of awareness amongst particularly the poorer populations is not nearly as high as it could be. And the efforts to educate patients, I think, are there, but I'm not sure they're always reaching their targets. I think there's a huge opportunity in all our health systems to find ways for listening to patients' voices and to hear patients' stories, because that's a very important way to supplement the wider data collection, which of course is so important, but you must also, really understand where the issues arise, is to speak to patients. Mm-hmm. And this is part of quality improvement and looking at whole systems approaches to improving disease outcomes, whatever that disease might be, is that there's no point in putting incredibly expensive treatment systems in place if patients are not accessing it.
Correct.
So I think this the huge move towards patient-centered care, listening to patients, understanding from the community level upwards what the issues are, is a really important approach to any disease control.
Great. Washira, for this one, this Washira is at the end. But again, for pharmacists, those who are pharmacists are also pharmacists, so don't beat me up. The reason why I put it in the legs of the pharmacist is the last person a patient sees before they start care. It doesn't matter wherever you are. He should be, or he or she should be, the last person to audit the system and say, yes, you need Panadol, or yes, you did not need Panadol, you needed something else. But at the moment, I don't think our system allows that. I remember when I used to work in hospital somewhere, there is no patient, if I'm on duty, there's no patient who will get any of the medications unless I say yes. I had to audit it, and I had to look at what else have they gotten, what are their labs like, then I say yes. Not you put it and then you say, oops. No, there was no oops. Now, when you talked about the HPV, which is a big issue. I remember somebody calling me and telling me, my daughter needs to get it. Should they get it? I told them, well, my daughter got it. And now there's also a thing about sons getting it too. So what is the issue? I know there's a religious thing going on, or there's something about birth control going on. What are you guys doing to increase the awareness for this? The need to take the HPV vaccine and the safety part of it. You know, we're talking about the safety issues here now.
So thank you very much. And I think at the beginning you alluded to it, vaccines being a victim of its own successes. The fact that the diseases that used to cause mortality, morbidity, are either eradicated or near elimination, then there is no association, or rather the awareness among the public of linking the vaccines to the outcomes to improved quality of life, then is a bit low, and that affects the uptake. For HPV specifically, as you have mentioned, we are struggling, especially in Kenya, religious, beliefs and objections. We know that there are fertility issues. A HPV vaccine being linked to, effects of adverse effects on fertility, even if it's not true. It's misinformation, which then is causing distrust in the vaccines.
Excuse me, Washira.
Yeah.
I would like you to say that better, because as what you said, it sounded like actually it is linked. So I want you to make it clear so that we don't come up with different, because I know that's not what you wanted to say. Repeat that, please. Hey, erase what you heard. Okay, repeat what is about HPV.
Yeah, and thank you very much. I'm talking about misinformation. Misinformation about a HPV vaccine being linked to infertility, being linked to, promiscuity, which is not the case. And we are also living in the information age, where misinformation somewhere is misinformation everywhere. Something comes up on Twitter, something comes on Facebook, and within hours it has spread across. So it is becoming more and more difficult to respond, to identify signals of misinformation and respond. What we are doing as the Minister of Health and Vaccines Program is that we are investing a lot in social listening and rumor tracking, which means that on our social media platforms, we are actively engaging the AI systems to be able to identify signals of negative sentiments towards vaccines. Where are these sentiments coming from? In terms of geography, in terms of social media use, demographies, and so that we can adapt our messaging so that we can give factual information. Okay. But even beyond social media listening, we're also doing active rumor tracking. Okay. And this is linking the vaccines uptake to community health systems. We have a very agile EACHIS system.
Yes.
And healthcare workers, especially community health promoters, are able to get what is happening, or the connotations within the communities, and they're able to report that using the EACHIS. So on a day-to-day basis, we are able to tell what misinformation that is existing and which population that is being affected, so that we can then use that information to adapt our messaging.
Great.
But even beyond that,
Uh-huh.
we are investing a lot in advocacy. We understand that the healthcare workers are part of the trusted voices. The pediatricians, the nurses, the clinicians.
Okay.
We have oncology specialists. Investing in advocacy efforts, so that now we can piggyback on the the professional associations to be able to correct some of the myths and give factual information to the public and the patients.
I have a question for you. It's a yes or no. Don't just a yes or no. Are you engaging the religious, faith-based organizations or the faith-based gatherings? Are you yes or no?
Yeah, but I would want to say just something. Yes.
Okay, half a minute.
Have a minute, yes.
Please.
So at the community, level, this is the leadership that we're engaging. One is the faith leadership, and number two is the community leaders. There is a role of the village elders. There is a role of the GAO, the chiefs, the sub-chiefs, local administration in addressing the misinformation and driving a demand for HPV vaccine.
Okay, include the. So for Emily, and I call her Emily because I respect she's a doctor and we're just colleagues. You talked about infrastructure at NCI. So the infrastructure that you're building for cancer, how are you borrowing from quality, ensure safety of the patient, ensure the quality is what it's supposed to be, what Dr. Choi was talking about, ensure that the data we collect and use it well, like what Joanne said, and then to make sure that the patient participates, like what Kerry said, and then also talk about the climate change. I'm giving you 3 minutes.
All right, thank you very much. I'll try to really summarize, because when you talk about cancer infrastructure, it involves many aspects, right from the infrastructure for prevention. Let me just summarize in the continuum of care, where we have prevention, diagnosis, treatment, palliative care, survivorship, and research. Okay, so you find that putting all that together, number one is that we're actually saying that every Kenyan should be able to access quality cancer care irrespective of geography. That means that patient in Lokichogio should be able to access that quality care. Though unfortunately for that patient, the nearest comprehensive cancer center, which is at Moi Teaching and Referral Hospital, would be about 1,000 kilometers. So that is why now we have decentralization of cancer care, where we have the regional cancer centers that are comprehensive, and more are coming up. We have Kisii, we have GTRH Kisumu. Of course, right now we have in the referral hospitals, that is MTRH, KNH, and KUTRH, that is Kenyatta. And we have the regional cancer centers at Nakuru, Garissa, and Mombasa. And now, these would be actually the hubs, and we believe and we hope that in the near future, we'll have more decentralization, so that we'll have more regional cancer centers in many other regions, so that that patient in Lokichogio does not cover 1,200 kilometers to get to MTRH. Now, on quality, we also have the aspect of actually ensuring that there is quality cancer care in various in the cancer centers, not just this, but all the cancer centers, by giving technical support, so that of course KMPDC checks on quality on healthcare as a whole. But when a cancer center is established, we are actually invited to give technical support to ensure that there'll be quality care in this particular facility. And that involves infrastructure. It also involves the healthcare, the HRH, that's the oncologists and all the oncology workforce. And of course, in all this, we also look at capacity building. Yeah, so we are also involved in capacity building, and that is one other main aspect that we do have, capacity building for oncology workforce, so that even as we progress and as we continue improving in our healthcare, which has really improved, and we look forward to when we'll have early detection as we are working towards it, because we have the aspect of prevention and we are really driving the agenda of screening that will inform awareness, that informs the need for screening and the demand, therefore, for screening. We'll have more people being screened, therefore catching the disease early, so that we don't have late diagnosis as per what it is now. We have over 70% of cancer patients coming in at late stage disease.
Okay.
Yeah.
So I'm going to, so everybody has going to have a minute to summarize, and this is what the plan is going to go. What lesson do you want anyone to take from here as regards to quality and safety? How do you want us who are listening to participate? And if I'm a clinician, what is the one thing I'll tell my patients so that they become part of it? We often, the reason why I say the patients are not as informed, we often speak over them. But remember, when a patient comes to you as a clinician, you'll see them for an hour, once a month. So that means you see them for 2 hours once a month, if that, but they have to live on their own. So if they don't have the empowerment or the knowledge, they are going to screw up for sure. One more thing that is personal. My wife went for checkup and was told after our ultrasound that the lump that she had was okay, come in 6 months. She got home and said, no, there's something wrong. I called a colleague who went and did imaging with the same equipment, patient safety, and found that this was not something to come back 6 months. In 2 weeks, she had had her surgery. She was aware of herself. She's the one who said, no, there is something wrong. So the question is, how are we going to empower our patients to be able to say, there is something wrong? How do you do that? So maybe we'll start with Washira, come down. 1 minute, 1 minute, 1 minute, and then.
Thank you very much. I think for me, with the focus of HPV vaccination and the perceptions and misinformation, what we can take home from here is whose role is it to fight information? And in responding to that, then I want to refer to, I think it is John Donne sonnet on For Whom Does the Bell Toll? It tolls for thee, it tolls for you. We see patients, we see clients wherever we are, and we have, we can support the ongoing misinformation. We can support the program by giving the factual information, advocating for more uptake of HPV vaccine. Currently, we are at 58% coverage. We want to get to 100%, or at least at par with the childhood vaccines at 90%. So creating awareness, using your social media platforms to spread positive information and factual information about HPV and the benefits of uptake in prevention of cervical cancer.
Thank you, thank you, thank you. Joanne, it's your chance now.
Okay, so I think I'll talk about the quality of data and a bit of on research.
Yes.
So on the quality of data, so the quality of data that we have is also a reflection on the quality of data that's being recorded by the health professionals at the facility.
Correct.
So if some information, for example, on staging is not put into the records or age or residence. So that will be missing in the overall data of the nation. So I think one call would be to everyone, like everyone being aware that the information is really important for us to understand the cancer trends in the country and also understand etiology. So I think we've been at the forefront in capacity building and also championing for like quality data from the facility level. And then on research, so I think on research, we have a lot of research programs or projects across the country. But then when you talk about genomics and you talk about registry and biobanks, so we find we have small projects, 50 world genomes, 100 world genomes, but then as scientists or as researchers, can we come together and pull this data into for example, a reference center or a system where all of us can use that information to actually understand the cancer that we are seeing in our population. Nice. Because you'll find that in the northern region, the trends are different from the Garissa or the coast. So you'll have the cases, the common cancers are different in the different regions.
Okay.
So I think, yes, I think I think with the KUKA and the universities from all these regions, so we have to come together and actually address some of the things by scaling up or pulling the data that we have. So thank you.
So quality of data, and that depends on the whoever is putting it in. So garbage in, garbage out, right? Go for it.
Thank you. I want to call upon all of us addressing cancer burden in our country requires all of us. So I therefore call upon all of us, multi-sectoral approach. It doesn't matter where you are at, it doesn't matter the space in. Addressing cancer is not just for the healthcare workers. Let's look at right from prevention. The herbicides we use, the pesticides we use, could they be the carcinogens that is getting into our water, our soil, our water, and therefore getting into the food chain, and therefore getting into our bodies? Let us consider that. And therefore, cancer prevention and control rests upon each one of us. Number 2, creating awareness. Yeah? And number 3, getting screened. Are you in that eligible population for screening? We have screenable cancers, and unfortunately, those are the cancers that are most prevalent in our countries, and they are the cancers that are causing the highest mortalities attributed to cancer in this country. The first being cervical cancer, next breast cancer, third is prostate cancer, esophageal cancers, and colorectal cancers. All those are screenable cancers. So all of us, I'm calling upon all of us to chukue jukumu letu and let us get screened. Let us get detected early in case there's a disease. And of course, prevention. Prevention is key. Let us address the carcinogens in the environment. In this era of climate change, we cannot just sit back. We've got to stand and address that.
Great.
Thank
Passion
you.
coming through. She even used language, right? Okay, go for it. Karen.
Okay, so my takeaway is back to quality again. We know that there are at least 8 million deaths a year worldwide that are due to avoidable factors, due to system errors. More than 50% of those 8 million are due to system errors, and yet we don't train our healthcare staff to improve their systems. So my plea is that healthcare staff everywhere should understand the dimensions of quality. Quality is care that's patient-centered, it's effective, it's efficient, it's timely, it's accessible, it's safe, and it's integrated. So we must pay attention to all of those different dimensions. When we loosely use the word quality, it needs specific attention, and we need to have more awareness, I think, amongst our healthcare staff about what true quality is, and give it special attention, and that in itself will save many lives.
Thank you very much. Amit.
Yeah, allow me to just also connect the dots. You started asking me with a question about the chronic kidney disease now, and the question is very pertaining. How are you going to create that awareness on the patients? I want everyone to take a step back and let's talk about people, not the patients, because it's the people like us who become a patient. Now, I'll give you an example of what AstraZeneca did in. So there is a program that we run, which is known as Healthy Heart Africa. This is the longest program, at least I've ever seen in the industry, with 30 years. It's a philanthropic program, nothing related to any brand or commercial benefits. In 2014, we started this program in Kenya and in 9 countries of Africa with the purpose of screening patients for hypertension. The program still runs 12 years. And I'm going to throw some data which will tell you the magnitude and maybe answer your question. In last 12 years, we have screened close to around 81 million people. 81 million patients. And any guess how many patients were having hypertension? 14.5 million who were completely unaware that a disease like this exists. So alone, banking on the patients is extremely difficult. I think this forum is that all stakeholders. So we collaborated with the Ministry of Health. We were partnering with KCCB. 2024, we started a phase 2 where we now have started screening the patient for CKD. In last 1.5 years, we have been able to screen almost around 315 high-risk patients, high-risk diabetes and hypertension patients of CKD. And this would have been impossible if, banking on the patients are patients, so people are people. Of course, we can create awareness. You are absolutely right. Media campaigns, we can leave literatures, pamphlet in a doctor's chamber. Yes. Will it help? To some extent, yes. But I think if all stakeholders come with the programs that we do, and we did it just because we know that there are patients who are going to really be benefited. We have got someone by the name of Margaret in the room. Margaret, in case if you can stand up, she leads this whole program for AstraZeneca. Anything that you want to collaborate after this, and this is the purpose. Please feel free to talk to her because she is running in 9 countries.
Great, great. Thank you. Passion again. You see the passion. Okay. Now, finally.
Thank you very much. Allow me my parting shot to just share the goals for the World Patient Safety Day 2026. It's usually September 17th is the Patient Safety Advocacy Day. And the theme for this year is very important. In line with what my brother has shared, it is NCDs, non-communicable diseases. And so the first goal is we are told to partner with patients, those who've had lived experiences. At times we design care and not factoring the ones who are using that care. So partner with people who have lived experiences and with the civil society. Goal 2, to strengthen prevention and risk assessment. And goal 3 is to provide early detection, accurate diagnosis, and integrated management, and not people going everywhere and they're coming from this lab to the other doctor across the hospital. So coordinating that care, because these are chronic care patients. They don't need to be doing spaghetti diagrams in our facilities. Then goal 4, secure access and safe medication and medical device use. And goal 5 is to strengthen care coordination, continuity, and transitions of care, whether from primary to the other level. Yeah, so those are the 5 goals for the World Patient Safety Day 2026. And the theme is on NCD, safety in how we are taking care of the non-communicable diseases. And the icing on top of the cake is that I would say we always ask the patient, what is the matter with you? Today, what are you coming for? We should change that to what matters to you. Especially patients with chronic care diseases, they have preferences, they have things they want adjusted, which would help them comply more to their treatment. So what matters to you? Maybe you can just repeat, what matters
to you? Nice.
Great. What matters to you? That's what we should ask our patient. Not just treating the bacteria, the fracture, but finding that there is a person behind that whole disease or that whole condition. Thank you.
Great. And that's amazing, right? Come on. Let's appreciate that. I think one thing we have to realize is the dynamic of our diseases has changed to NCDs. The health-seeking behaviors of NCDs and then communicable diseases is different. You used to give 14 days, go do Kimaliza Enda, you're fine, right? Now you have to go every single month. And also you have to take your medication every single day. With or without, I mean, you need now to be more involved in this. When I used to call my parents, and I still do, and I used to say, I'm taking a white pill. That used to drive me nuts. That tells me she was not informed what she's doing. So she doesn't know, she wouldn't tell you the adverse effect or anything. White pill, what's a white pill, right? She doesn't know whether it's gonna give her dizziness, whether she needs to eat it with food, whether she's at the bedtime or in the morning. White pill. We need to take more time to explain to them such that it fits in their lifestyle, they understand how to use it, and they will become partners. Because after all, it's their health, right? It's not ours, it's theirs. So what matters to them, and how can we best support them? Thank you very much, everybody. And, oh, no. I have questions from outside. I'm gonna have questions. We will have 3 questions, maybe? Okay, start with Professor Kika.
Yeah, thank you very much. I think you have touched on 2 areas of very major concern. We've done very well in treatment, but there are areas that we are lagging behind, and 2 areas that Amit talked about and all of you. Number 1 is awareness at all levels, and number 2 is screening. Let me start with awareness. It's amazing, like what we do in Eldoret. You get some patients diagnosed stage 2 cancer, they disappear. They say they go and get a herbalist, or they come back stage 4, then they say when you go to hospital, you die. Number 2, look at what's going on in Congo now. The part of the spread of Ebola is many people do not even believe that there is a disease. They will go and steal their patients from hospital, and the cycle goes on. You talked about pharmacies. Nowadays, because of AI, people have gone to school. Immediately a drug is prescribed, they look at the adverse effect, and then they say this drug can cause cancer, or it can cause what, so I'm not taking it. There are people who still believe they don't want to take chronic medicine. People want to take, like from my community I come from, people just want to be treated a one-off. If you tell them that they are going to be taking every day, it's a nightmare to understand to them. So I think there are several approaches. Number 1, you will find that if you go to some areas, you get somebody who says he has just some headache. You take the blood pressure, it's severe hypertension. You are shocked. He says he gets dizzy sometimes. You take the blood sugar, it's like 15, 16. So the issue is this. I think, and we are discussing with somebody this morning, I think we are all doing good things, but it is not coordinated. Correct. We should have a coordinated front. I was in Tanzania, and there's a radio program. Let me talk about the one of security. After every 3 weeks, somebody comes from police, and anybody can ask any question. If we could have like that for healthcare, where everybody would know, like, and maybe sponsored by AstraZeneca or anybody, a program, or even part of what we are doing today, so that they would know awareness and ask any even ridiculous questions. Number 2, screening now, so that they can take over. I'm sure the vaccine cover can go up and people will be healthier. Thank you.
Very, very good wisdom. Oh, I'll come back to you.
Thank you. My name is James Nono from Maseno University. So I would like to appreciate the role of National Cancer Institute, particularly in policy and providing framework to manage and prevent cancer. And I've taken home message, the need to sensitize the population about screening. But my question is, could you share the scope of a National Cancer Institute with respect to providing support for screening services, particularly to these regional cancer centers? Because we know there is a problem with the county governments with respect to capacity, and also they sometimes talk about funding, which I don't think is a problem, but capacity in terms of the technical expertise, but also with respect to facilities. Could you share the scope of the Kenya National Cancer Institute? Thank you.
So we're talking about money there. I hope you are jotting your questions because I'm not writing them.
Thank you very much. I'm enjoying the passion in the fight against cancer, especially listening to Emily Barcito. You are so passionate about cancer care. And now I'm asking myself, when HIV came, everybody feared it, especially here in Kenya. You hear somebody has HIV, they know you are going to die. Even your brothers and sisters start planning past you. How are you even to share the land? Now, things changed when we got quote unquote free medication, of course, sponsored by US and other things, other places. So now people no longer care about HIV. Actually, the problem is cancer. I saw in the video that was projected earlier, the gentleman saying he thought it was a death sentence. He thought there was no hope, but now he knows better. And I support my colleague, the professor here, who says we need more awareness. It's just actually a radio program or an online program, YouTube, and everybody will be listening. Now the question I ask, how comprehensive is the care of cancer patients, especially thinking of the universal coverage by SHA? The reason why most people shudder and think it's a death sentence is your drugs are not assured. You'll be tossed left, right, and center, and at the end of the day, you have no way out except a few people who can either fly out or go to expensive hospitals. Madam Emily, will kindly comment? Thank you.
The cost of cancer care. Cost and provision of cancer care.
Yeah, good afternoon. My name is Sam Kenyanjui from the Camera Welcome Research Program. And maybe I just wanted to comment and ask a question related to misinformation. And I've heard some of my colleagues talking about it should be a radio program. And I think institutions need to take this responsibility. Nobody else is going to do it. So Moi University has commented, Moi University should take up that task.
There you go. Dr. Keegan, Professor Keegan
just got a job.
I
can put that challenge because Camera Welcome does a large number of radio shows. So for example, during COVID, I was involved in going to Ghetto Radio and talking about COVID in Sheng. So let's not say somebody should do it. Let's say our institution, Moi University. And why is it important, especially universities, to do it? Because they have the credentials. People look up to our universities. They're waiting to hear from the professors there. They're waiting to hear from professors. We don't stand up to be counted. You often find that the person even making comments on newspaper or to radio teams when they visit a place where there's an outbreak. And I'm saying this very respectively, but he's a person who is not an expert, say, epidemiology or in that particular disease, but they pick up, there's a nurse walking past or a doctor, whoever, I say, hey, you, can we ask you a question about this disease?
Yes.
So that's important. The other one, maybe now as a question, in terms of training scientists to communicate. Because as long as we keep quiet, people assume that the misinformation is true. And too many of us are too scared to be seen to be controversial. So I think it's important for you to comment on how we can enhance the confidence. It's not so much the information, but the confidence for scientists to stand up and be seen and be counted. And take the risk of being seen to be controversial, saying, yes, HPV works, regardless of the fact that in your whole WhatsApp group, everybody's saying this thing is bad and everything.
Thank you very much. You have one? And then we'll go back to the answer. Just go ahead.
Okay. My name is Wandia from Center for Health Solutions Kenya, an NGO in Kenya in public health sector. Now, this room, all of us are in public health space. We are speaking to ourselves. True? You talked about, thank you for speaking about multi-sectoral engagement. Can we take it and swear, okay, not swear, commit from today that we shall be inviting those people who affect what we do? For example, you talked about carcinogens. Could you have invited the Ministry of Agriculture, those guys who regulate the chemicals that come here in such a forum, so that you don't just go to them when you're condemning them, you're with them when you're discussing the actual details.
Yes.
So that in policy making, you have details and you're able to influence. The other thing, we always say we want to change things, but we are talking to adults who have other responsibilities. But there's a fact from the social science research that children are very good agents of change. True? Yeah? Yeah, your child, tell them to remind you about something. You will be dead because of the amount of pressure you'll be given, because they don't forget. So why aren't we using that approach? Moi University has a primary school. Use it to the extreme. Kenyatta University, all these universities represented here. Let's start there and see what happens. And then we document that and push Ministry of Education. Let's start from what we have. I'm a person who is addicted with working with the little things I have. I'm inspired by Moses. I'm a Christian. With the road. What's in your hand? Because we're always singing about we don't have resources, we don't have the money. But what do we have in our hands? Thank you.
Okay, so who's gonna start? If I give you, you'll okay, just finish. On the podium, and then you had your story. Start.
This is how I want to start. Can you hear anything? Can you hear? Okay, I'm tapping my feet. Can you hear? Okay, can we all tap? Can we hear? Good. That is what I'm saying. That you know what? Multi-sectoral approach, starting from the scope of NCI when it comes to screening. Okay? Now, I have said that NCI gives the technical support. And in fact, in literally all the counties, we have actually worked with the county governments to develop their county cancer action plans. That is the tapping of NCI. But we want all the counties to now tap their feet. And we know one thing is that screening is actually a service that is provided in level 2, level 3 health facilities. And so one thing we appreciate is that health is devolved. And so even as we worked with the counties to develop their county cancer action plan, is because we want it rolled down all the way to their level 3 facilities, so that people can get screened in the facilities that are near them. And so in that aspect, NCI gives the catalytic effect. And when we normally visit the various counties, of which I think like right now, we've literally gone to all of them, yes, is that we have, at a certain facility, we actually give just a few commodities and demonstrate, like with the HPV oncology, HPV test kits, and we find that as we do that, we are able to actually do capacity building for that particular county. The facility, the health workers who are there at that point, and then they replicate the same. A good example is we've gone to Turkana and they are replicating that. Samburu, the same. Isiolo, the same. Kisumu, Lamu, literally everywhere. I think the only county that we may not have dealt in so much, but we have done a bit of it, is this Nairobi County. Great. So that is when it comes to the scope and the screening in counties. Okay. Then when it comes to there were 2 questions. Yeah, the bit of cancer being a death sentence. Now you find that in our country right now, as Professor said, is that people come, they are screened stage 1 or stage 2, then they disappear, they show up in stage 4. And you find that in most cases, because of our health-seeking behavior, most cancer patients show up at stage 4, late-stage disease, actually over 70%, when the treatment options are very limited, associated with poor health outcomes. So what are we saying in this case? That, of course, the information, education, and awareness will create the need for screening and therefore early detection. On the bit of SHA, you find that we started, when SHA started, the oncology package was only 450. And we kept negotiating. Remember, we said we bring on board all stakeholders, yeah? And SHA package moved to 500 and now at 800, covering both diagnosis and treatment. And we hope that it will keep going up. But remember, I told you just the way I tapped my feet alone and you could not hear, but when we all tapped together, yes, we all have something to do. Multi-sectoral approach. Thank you. 800,000 from 450,000 to 500,000 to 800,000. Oh, yeah. Sorry. Yes, 800,000. I mean 800,000 from 450,000. And remember, this is per year, and cancer treatment is a journey. It's a journey. So that means it will be covered in those various steps all the way in the journey. Thank you.
Yeah. Thank you. And I wanted to add my voice to the discussion on, or rather input on creating awareness and addressing misinformation through the radio stations. It's a very good idea. It has worked. And I also, the idea of now the academia, the research scientists also getting into that space is also very good. It's also good to expand the platforms to social media. There is a group that listens to radio and watches TV, but there is also the younger generation, the Gen Zs, the Gen Alpha, who get a lot of their information through the social media. There is a place for X Spaces, TikTok Lives, as a way of reaching out to the younger populations and also creating awareness. As we do our radio, we also remember that. In terms of training scientists, we have, most of the times we have invested a lot of focus and efforts on the mainstream, going to the counties, and also looking at the teachers, the Minister of Education. But I do agree there is a place for training the, also collaborating with the academia, institutions of higher learning, and the scientists at that level. And that is a good opportunity to also explore on things. That were my additions.
Great. So, what did we learn today? I want now to get the lessons. Anyone shout out whatever lesson you had today. What did you hear today? Multi-sectoral engagement, that's one. What's the other one? What matters to them? What matters to them? Any other? SHA money is now 800,000. Screening is very important. By the way, do you know who are the worst at screening? Who? Medical workers. We talk about it and we don't do it. Because I'll ask even now if you're brave enough to say, how many of you have been screened? There are people here who are over 40, right? How many of them have had colonoscopies? Or pap smears? I know a physician who goes to women, and the worst part was when he asked somebody very senior in front of me, have you had your pap smear? And I did not know what to say. Because he's encouraging that. I think Dr. Kigondu is very good at that. Anything else? 14 million kidney disease in Kenya, right? In Kenya? 3.1 million kidney disease in Kenya. I remember one time we were at Kenyatta, this lady comes in with the black toes. I think two digits were black. Necrosed, kabisa. And that's the first time she knew she had diabetes. So they were discussing how high should they cut the leg. So the question was, where were you when that toe started until now? It is absolutely, you could see the bone, right? It was literally gone. And then you could see the gases outside moving up. That's when she knew she had diabetes. And yet, we don't have access to, and that's why innovation is here. How do we test blood? In other countries, somebody takes their blood sugar before they eat, after they eat. They have like they're given 6 strips a day to test several times. And then when you collect that data, you can now come up with a picture of, is it Samoji or what's going on here? Which foods push you up, which ones push you down? What are you? We don't have that. People can't afford strips. So we have to really look for ways for affordability and for patients to understand themselves. If you understand yourself, then you'll know there's something wrong. So there is tea outside. That's number 1. Treat number 2, that we are, PS Oluga is here, finishing from the other side, the people who are doing pitches, then he'll come here for a closing address session. So a question was, suggestion was, let's enjoy the tea. By the way, they're not here, so all that is ours. We can start now. Bele, top layer. So we enjoy the tea as they come out. They should be coming in the next 10 minutes, 10, 15 minutes. Then we have the closing ceremony together. I really have appreciated, George. The involvement, the engagement has been really cool. So thank you so much. I don't know what else to say. I'm going to ask maybe Elder Professor Keegan to say, he had something to say about data. He'll say it in half a minute and then just say, give a vote of thanks to the panel. I know it's an ambush.
Yeah, really been ambushed. But then I was just in a meeting recently somewhere, and somebody mentioned something that the next area where you're going to get money is not oil, but data. What do I mean about that? That very soon everybody will be looking for data, medical data, for research, for all others reasons. I don't want to talk about the others, the bad side. I know. So I don't know how, and that's how we can secure our data, because from what I was listening to, I think our data is not very secure. That was just, how can we improve on that? Thank you.
Yes, please.
And on that, thank you very much. I would like to thank everybody who's been around, and we've all listened to a lot of new things. And we would like to, do you want me to do a vote of thanks for overall or for them? Okay. And I think this was a very important meeting for me personally. There are a lot of things that we've learned. Others we already knew, but we didn't know the how. And I think going back, we all have ideas of what we are going to do, although somebody said we are talking to ourselves. And I think we really have to think of how to disseminate this information, not through publication, but how to get everybody to know. Other than that, I would like to thank the organizers, the participants, the panelists, and all of you. This was wonderful. When we started, I was almost giving up, but we've ended up on a very high note. Thank you very much.
We can have our tea, unless there's something very burning that you want to talk about. It took off. You see, there's nothing burning. Everyone took off. Great. Thank you so much.
Officials now in the spirit that we started, to continue with the deliberations. Thank you.
Thank you very much. We are privileged to have
described what they may do about that. So this module now is able to be strengthened across the country and reach across the system, particularly healthcare workers who will have the most contact with people. So in cancer, we have 30% of cancers that are preventable, something called cancer etiology, where your environment and your behaviours create cancer. And if we can start to talk about cancer, we can start to reach the community. So the challenges we found was often health professionals are uncomfortable to talk about cancer and they feel it's quite hopeless and leading to death. And we know that if we get early intervention and public health messaging, we're able to change behaviours, but also encourage people to have early detection, early diagnosis that makes things much cheaper. So a nurse colleague at the back came to me and said, how do I get trained in this? And I said, well, actually, the nurses should become the trainers. So the model's sustainable. It's owned by the local community and the initiative less. So as the landscape changes, the community can respond to that change with the public health messages. So we're so happy that the module, everybody on the module is Kenyan. There's not a European in sight. Nobody understands my accent anyway, so they understand the module. And this has created the blueprint now for Uganda. So we're now going to go to 4 counties in Uganda, and Kenya has led the way on the model, so congratulations.
the next voice will be for Graham Lord, who will be speaking about health workforce and leadership, which is a vision which has come out of African leadership here in Nairobi, a partnership between King's College London and the University of Nairobi.
So thank you, John, and on behalf of the UK side of the Kenya UK Health Alliance, welcome to my very, very good friend, P.S. Aluga. We talk about healthcare system sustainability. We've been talking about it for at least a year since King's College London signed an addendum to the Kenya UK Health Alliance MOU in the presence of your president in London in July, end of July last year. And we keep coming back to the same question that we're all trying to solve. And I apologise if people are sick of hearing me use the same terminology. It is our Nobel Prize winning question we're trying to address. And we figured out in our previous session, it's actually the Peace Prize, not the prize in medicine. Because actually without a healthcare system, we don't have peace and we don't have prosperity. And the tenets of the question we're trying to address are, how do we make sure that the healthcare system is sustainable? And I always say it's about the money, it's about the people and the workforce, and it's about the environment. That's what I mean by sustainability. The second thing is, how do you make sure that the healthcare we deliver is of high quality? Because it's easy to deliver healthcare if it's not very good, so quality. And also, how do you ensure that everyone has access so that UHC works? And what's the structure around that? That's very difficult. Most healthcare systems around the world trade off at least one of those. The biggest healthcare system in the world, the US, trades off 2. And clearly you need all 3 at the same time, and nobody knows how to do it. All of those 3 answers to that question require a sustainable workforce. And we know that, by WHO predictions, by 2030, the biggest workforce gap will be in low and middle income countries. And there are a variety of reasons for that it may be that the PS will go into, but I think we know in this room many of those reasons. And I think also the nature of how healthcare needs to be delivered is changing. It needs to change because we don't have the fiscal headroom just to train more doctors, even if we could, because the exponential rise in demand as populations age and we get clever at treating disease linear solution will not solve an exponential problem. So how do we change the way we educate our healthcare workforce? That isn't just about doctors. I say that as a doctor, I'm allowed to say that. And how do we empower our community health promoters? That is a brilliant vision that you're executing already in Kenya. How does all of that fit together? I think the African Leadership Centre is a partnership between King's College London and the University of Nairobi that's existed in physical form here since 2010. It has two strands currently of leadership, peace and security, and then African female leadership. And as part of our signing of the MOU, you may well recall, and it's Funmi Olakasin who runs that, who's here tomorrow to talk about the detailed plans, we're adding a third stream to that of health systems leadership. Since 20, the African Leadership Centre has brought in about £25 million of philanthropy into Kenya, with some seed investment from both of the universities. And I think what we've thought about is how do we think about healthcare workforce as a systems problem? And how do we deliver the leaders of the future that think in those terms, as well as how do we run our hospitals and how do we change our curriculum? We need to do all of that at the same time. And I think KUKA, King's College London, and all of the UK partners are absolutely committed to working with you and doing that brain work, as we talked about in the previous session, to come to a solution. How do we turn policy into practice, and what's our strategy for doing that? I can't think of a more important discussion to have as part of KUKA about workforce in all of its forms, because at the end of the day, healthcare is a people business. We will use technology, data, digital, clever new treatments to enable that. It will always be a people business. It will be, how do we look at the health of our populations, or how, as a healthcare worker, do we look after the health of the person sat in front of us in one-to-one?
Yes. But it's a show of commitment as well, because in the past few years, from what has happened globally with the global health initiatives, very few people are talking partnerships. I think that's really courageous. And I think if there is, for me, one thing that I was telling the team there makes me a bit emotional is because of that we're still talking about partnerships, this was a buzzword long time ago, and it did quite a bit. And there's still lots that we have to do. There's a lot of unfinished business. And this Kenya-UK Health Alliance has a lot of results to show for it. We've done quite a bit of work, both at institutions level, at people level, at country level, and there is a lot of results to show for it. We have our integrated molecular imaging center to show for it. We have all this amazing research work to show for it. We have some of the trainings that we've had building capacity for our health workforce to show for it. There is quite a lot of exchanges, including the organizations for diaspora in the UK to show for it. I think there's a lot of exchanges. Last year, on the 2nd of July, we were at King's College London with His Excellency the President, and when we were walking out, he mentioned to me that this is one of the most useful meetings I've ever attended. And I remember the discussion the previous night as we were trying to get his calendar, and people look at there's the protocol and all these things, and is the UK government going to be there or not? And then we came for that meeting, and then he, perhaps being a scientist, he was really enthused by that. And I know you're good friends already, so perhaps it was your messaging, or perhaps it was the people you brought in the room. But I think there is real commitment from the Kenyan government, just like there's real commitment from you, just like there's real courage that you've shown to still have this conversation about partnerships. And right now, 5 years down the line, there's a question in our minds: how do we scale this up? How do we make this better? How do we solve the challenges that bedevil healthcare systems? Healthcare systems all over the world are facing serious challenges, There's no single country that can say that they have it all covered, not one. But there is also a lot of knowledge and a lot of solutions where you sit, a lot of ideas that have come forth that you have co-created or co-convened in terms of trying to match solutions with the problems that you see every day in the course of your work or in the course of your research. And I believe that's the question for the next 5 or 10 years, as Professor Graham talks about it. Like, what will we have to show in 5 years' time? And you know, many places in the world, the 5-year mark is a big mark. It's a mark of maturity. It's a mark of we can do better. It's a mark of we've overcome. It's a mark of it's just fine. I think if you didn't die business-wise or neonates, if they get to the 5th year anniversary, then they are now expected to thrive, you know. So how will we thrive moving forward? And there are a couple of thoughts that I know you shared across the board, either sharing the science or sharing the solutions that you think through. But there are a couple of thoughts. One of them, Professor Grant keeps talking about the sustainability. I think there's a big question that healthcare systems all over the world want answered. How do we become sustainable? But before we answer that question for the healthcare systems, we have to answer that question for ourselves. How do we become sustainable as KUKA? And that's also an important show that we can actually solve that problem for the world. But the second thing that is quite important is how do we solve the problems of the people? How do we unearth the solutions that are in this room? How do we scale them up? How do we embed them in the policies and the practices that are there? From where we sit, and I meet a number of colleagues who are principal secretaries, who are ministers. I sometimes send it to ministers meeting in Africa and all over the globe. And everyone is describing problems. Everyone is describing problems. Except that there are solutions. Those solutions don't exist in those rooms. Perhaps those solutions are here. So how do we take those solutions to the world stage? How do we scale them up? Because people need them, populations need them, governments need them. And how do we bring this structure, this institution, this partnership of KUKA to be a solution provider to healthcare? How do we do that? And how do we do that at cost? You know, how do we resource it in a way that that taxpayers and banks and investors can take it up? And I believe this is the work that brought you here. I think that's why I say that I have to come and speak to you, if for nothing, to put more burden into your brains, because I know that that is why you're here, to think for us, so that you bring for us solutions that we can just uptake. How I can use the money that we have to solve more problems, You know, Kenya is one of those countries that is quite intentional about healthcare right now. And there is alignment of stars in terms of political commitment and political leadership in this area. We are keen to see our healthcare systems become sustainable. Our thinking of sustainability is that we put our money where our mouth is, but first we have to collect that money. And therefore we are very aggressive in our domestic resource mobilization through taxes, through contribution. But more importantly is what should that money do? And we welcome a lot of ideas. Our thinking is very simple, that the money should stop Kenyans from dying. And number two is that the money should stop Kenyans from going into poverty while seeking healthcare. And so in between there, again, is a lot of work. It's the work of research. It's the work of how we redesign hospitals, we redesign health workforce. this morning we had this engagement with our UHC workers. We have now launched a campaign to reduce maternal mortality, neonatal mortality. And there's always this question about health workforce that is lingering. I come from that background. I spent 8 years leading doctors as the Secretary General of the union. And so I know it very well. It's work that I'll carry to the end of my life. And so I believe the workforce is actually the system. Not to mean that the worker can deliver without all the tools that they require, but you build a hospital, you put a CT scan, you give them the medicines, but then it's the worker that determines what happens. The worker that determines how the people experience healthcare. It's the worker that determines if there is quality or not. It's the worker that determines the outcome. And so in my simplicity of the healthcare system, I just say the workforce is the system. And then so the workforce is a very integral part. And sometimes you put a surgeon in a place where there is no theater, but the surgeon can then design the theater. The surgeon can write to me and tell me that I don't have this room, I don't have a theater table, I don't have anesthesia machine. But then there's no theater that can happen without the surgeon. So this is really a fundamental shift. But the way that populations now want to consume healthcare is also different. The way that governments wants to finance healthcare is also different. And so how do we reimagine healthcare? Yeah, not in the traditional sense. How do we move from sick care, to healthcare, because I think we've done a lot of sick care, and in a way that improves experiences, reduces costs, in a way that also enables healthcare workers to be more healthy. The well-being of healthcare workers is also very important. And so within the health workforce question, education, well-being, how we design their policies, workload is very important. And I believe KUKA is well placed because you formed this partnership really anchored on health workforce. I know that there is a lot that we can do together, building the skills of the workforce, not just to deliver care, but for other initiatives that build the economy and bring resilience to healthcare system, like local manufacturing. We talk about local manufacturing. We don't have GMP training around here. We talk about local manufacturing. Many of our research do not proceed to innovation, and your topic is innovation, innovation. So how do we move from all of that research that we are doing, the publications, to innovation? How do we coalesce many of the knowledge that is sitting in the universities to innovation? Because without innovation, then there is no story about local manufacturing. And without local manufacturing, then all our agenda around resilience and security is dead. So everything is interconnected, but it's all about the people that do it. And you are those people. And I'll finish by just saying what we as government can do for you. We can set up very good environments, we can enable you, but more importantly is that we can scale up what you do, we can link you with the investments, we can back you up so that what you do shows up big. And that's really the only value of government, by the way. Government is not a knowledge place. Sometimes people expect governments to be clever. They will never be. Government is supposed to create an environment where your knowledge, your innovation, your solutions become big. They get connected to the problem that needs to be solved at scale. Okay. And that's the work that I want to do. And that's the commitment that we have from His Excellency, the President. And that's why we've established the health policy platform, so that there is an entry point of all of these solutions and ideas. You know, there is a place for ideation, there's a place for innovation, there's a synthesis process, and then there's a way to link them to the priorities that the government has put forth, which are only four. For us, health financing is key. Again, health workforce development is key. The issues around commodity security is key. We are very keen on digitization. We take data as a strategic asset for the healthcare system, not just for my decisions when I'm deploying resources or making policies, but also for you, because constantly you can save a lot of money in the surveys and use our data to do more research. And then that research can then come into the innovation, and the cycle continues, and we continuously improve ourselves. And so tonight, I mean, this evening, I'm here to tell you that we see what you do. We congratulate you for what you do, and we will always be behind you. But we want to have a lot more visibility, and we want you to be encouraged to do much more to strengthen this partnership. The government of Kenya is quite, you know, let me say, thirsty for, you know, this innovative ecosystem. I think you know very well what we've done in the IT sector. And right now, we just, you know, gave a charter to KEMRI, the KEMRI Graduate School, again, to give special degrees. KAIST, again, Kenya Advanced Institute of Science and Technology, again, was just given a charter the other day to show you that we're really thinking about creating a space, creating platforms for new ideas. We don't know those new ideas. We don't even know where they'll come from. In fact, I visited KAIST the other day at Konza, found a very beautiful place, very well built, but it was empty. You know why it was empty? Because it was waiting for you. It's waiting for these ideas, because the government's work is just to create the environment, to create the space, to give you the backing, and to put your solutions at the world stage, if not at the population stage. So thank you again to KCL and my good friend, Lord Graham, and all the visitors from Kuka, and I'm sure many of you are with us in the UK last year. I believe the next 5 and 10 years will be better, but we have to make them better. And making them better means a lot of work. You know, it's a lot of brain work, it's a lot of leg work, and that's the assignment that is before us. So thank you again, and I wish you all the very best as you finish your discussions tomorrow. We are here to do the best of what you bring forth to our tables. Asante.
It's amazing how the president says when we will put our best brains together to bring the best solution in the world. So we are on a journey. I want to take by your word, Nobel laureate will come from our partnership. And it's exciting that the 2 institutions which have walked the journey are here with us. Actually 3, because we have the Christie here, which have walked the journey. So it's reality when we say we will be the best in the world. So we want to thank everyone who has been here with us since morning, 8 o'clock, and you have stayed up to this time. We want to welcome you back tomorrow here, 8 o'clock. This is our final day, and we have big ideas for you. Nobel laureate is one, but solving our problems reciprocal is our journey together. So thank you for the Ministry of Health who have worked with us from the initial visit to Manchester. And I want to acknowledge Graham Lord, who left his teaching time to come and see the Kenyan delegation. And your words, you have kept your word. So we are here today. And I'm a testimony. I was never interested in global health until you said we can do it. So I'm looking forward to that vision. So thank you, everyone. And it is my pleasure to ask one of us to come forward. And if I look behind, there's an elder standing. Can you come and pray for us, Dixon? And we'll close. Thank you very much.
My assignment is simple: to ask us to stand in respect of this prayer. Father, in the name of Jesus, once again, we stand before you this evening with our thanksgiving in every lip, in every heart. We give you glory and honor. Thank you for giving us even your presence today since we started. Jehovah God, we want to thank you for being with us from the beginning to today. And we want to thank you for granting journey mercies to them who came, and for the word that we received, that it may even be of help to us as Kenyans, even around the world. We want to thank you for being with us even up to this minute. And we will ask you that even as we leave this place, Jehovah God, give us journey mercies, even as you protect us from all manner of evil. Until we come back here, we want to thank you, and we pray in Jesus' name.